Okay, so thank you very much, Professor Cato, for these words. We can start with the first lecture. Let me introduce Professor Lukas Rasulic. He is a full professor at the Faculty of Medicine, University of Belgrade, and he is also head of the Department of Peripheral Nerve Surgery, Functional Neurosurgery, and Pain Management Surgery of the Clinic of Neurosurgery at the University Clinical Center of Serbia. His main clinical and scientific areas of interest are peripheral nerve surgery, and he holds and used to hold several appointments in many relevant associations. He is president of the Serbian Neurosurgical Society, EANS secretary, honorary president of the Southeast Europe Neurosurgical Society. He has been also Congress President of the EANS 2022 and past chairman of the WFNS Committee for Peripheral Nerve and Brachial Plexus Surgery, and many others. It would be very long to list all of them. But I want to point out that Professor Lukas Rasulic is a project lead in Serbia for the project ENAID, the Academy of European Neurosurgical Excellence through Innovation and Diversity. Actually, his talk today will deal also about innovation and new techniques. And he published more than 800 scientific publications in international and national scientific papers in indexed journals and chapters in scientific books. And he has been invited as an invited speaker and faculty to more than 120 international courses and training courses. Today, Professor Rasulic will talk about innovation and research in peripheral nerve surgery. So a very interesting and intriguing topic. Professor Rasulic, thank you for joining us, and you can start your presentation.
Thank you for these kind words and introduction. Thank you for the invitation. I am always happy to participate in this outstanding educational events organized by Yoko Kato, by Asian Congress of Neurological Surgery, Wichita Health University. And now I will speak about innovation and research in peripheral nerve surgery. When we start thinking about why men always try to find something better to improve the quality of life of his patient, this is a simple reason, and the origin of this is from the beginning of the mankind. We are doing our best to improve everything in our life, in medicine in general, now also in peripheral nerve surgery, to implement everything what is in progress for the prosperity of each individual patient. And that's why we are talking now about innovation and research in peripheral nerve surgery. Current standing in peripheral nerve surgery is related to the impact on molecular biology level. And this will be the outline of this presentation. But beyond that, or before that, we have to turn back to the essential things in surgery in general, especially peripheral nerve surgery. This is hand of the surgeon and the surgical skill. So is the art in your skill, or the skill is in your art, and no master is born perfect? This is something which is very important to understand, that within the learning curve, surgical skills are very important to be mastered. And this is how looks when mentor and mentee are placing a microsurgical suture in vascular surgery, vascular microsurgery. And this means that beyond this technological innovation and improvement which we have on disposal every day, improving constantly, still hand of the surgeon remain an impact, major impact factor in microsurgery. And this is very similar, practically the same in peripheral nerve surgery in doing microsurgical anastomosis. These two slides are courtesy to my very close friend, Jacques Morcos. So now we are going to the subject of our topic. This is innovation and research in peripheral neurosurgery. This is the plenary session of the European Association of Neurosurgical Societies, which is related to the peripheral neurosurgery, which means that in the European Congress of Neurosurgery nowadays, we have plenary session related to the only peripheral nerves, and also parallel session and master classes. As you can see here, the whole spectrum of peripheral neurosurgery pathology is included in this session, and this is something what I want to present here, that so far peripheral neurosurgery was treated and still is treated somewhere within the general neurosurgery as ugly duck. And we are now doing our best in terms to improve the visibility and the raising an awareness about peripheral neurosurgery. As Yoko Kato mentioned, in many countries in the world, people are not doing peripheral neurosurgery within the neurosurgery regularly, but slowly but surely we are improving this in our everyday activities. So within this road, which is less traveled in the peripheral neurosurgery, you can see that there are analysis of the data revealed from 3,800 surveys that simple peripheral nerve procedures such as carpal tunnel release and lack of comfort, and the lack of comfort with more complex peripheral nerve procedures such as brachial plexus exploration are very common in the residency program within the world. My very close friend Karl-Heinz Land, investigator of the future, published this book in 2019, Earth 5.0, Provoking the Future, and this book received several new editions, meaning that technological improvement in nowadays in the world is developing fast and furious. So we have to follow all this. We have to have on disposal all this. There are many difficulties if you to have everything what is up to date and what is related to the last edition of everything what is related to the innovation and research in every field, as well as in peripheral neurosurgery. But this is very important to work on that and to try to find the best in this field to put on disposal to our patient. Cutting your nerve changes your brain. This is something which is many people are not aware that if just small cut on your finger or somewhere on your body, not to mention when your nerve is cut, that disturbs you in your everyday activities. And you can imagine what can happen when some major nerve or brachial plexus is injured, and there is a loss of continuity and function of the nerve. This is highly impact on the quality of life in everyday activities of our patient. So this is something which happened in the brain also when we made some of nerve repair procedures, especially nerve transfer, when within the brain plasticity some new changes in the brain happening in terms of reorganization for the better quality of recovery. These are standard operative procedures in peripheral neurosurgery today. These are like direct repair, which means neurolysis, external and internal, direct suturing, split repair, graft repair, and indirect repair. So direct repair and indirect repair are in two major groups of surgical procedures, microsurgical procedures, which are in armamentarium of everyday surgical activities in terms of reconstructive surgery within the peripheral nerves. These are nerve transfers. Thanks to this development and understanding of these procedures, you can help your patient with severe brachial plexus lesions in terms of restoration of the function of the functional priorities, which are elbow flexion and arm abduction, elbow extension, and then hand function. So you have a proximal and distal nerve transfers to implement following the preoperative evaluation in these cases. This is the series of 1,000 brachial plexus patients with a follow-up period of 2 years, which were operated in Department for Peripheral Neurosurgery Clinical Center of Serbia from 1980 to 2003. There are more patients which were operated, but this 1,000 are selected to be published in a new paper, which is now preparing with all type of surgical procedures, all type of lesion and level of the lesion of the brachial plexus, all type of pathology, and with a nice and solid useful functional recovery, which you can see here, depending on the different type of the procedure, which means M3 and more. As it mentioned on the introductory words, we are running. I'm running as a project lead this INAID project, and my department is the Center of Excellence in education and providing the service of the patient with lesion of the peripheral nerve surgeries, and this is the total number of the peripheral nerve lesions which we have in our database, with a minimum follow-up period of 2 years in terms of all type of nerve lesions which we handled in the last 43 years. So results are good despite the challenges. The results are good in this field beyond the facts that you have biological challenges, such as regeneration is slow, Stafford and Hazard, reinnervation is misdirected, non-specific and imprecise, nerve gap, or a nerve defect of the nerve tissue might be too large, and the neural tubes can be not intact, depending on the injury grade. You can have a scar and frustrated growth misrouting. You have a neuronal and targeted atrophy. You can have delay in terms of chronic denervation. But generally speaking, if you handle these patients in a proper manner, in adequate timing, you can expect good results despite these challenges. So if you consider this as an opportunity, you can have a lot of work, including innovation and research in this field. These are examples of the useful, good, and excellent useful functional recovery in our series, which are, depending on the procedures, are in correlation with the results in various series. So you can see, you can expect good results in 92% of cases in terms of neurolysis, 90% remain in terms of direct suturing, grafting 88%, and nerve transfer 72%. This is results in our series. This is very important. Quality of life after peripheral nerve surgery was not investigated until a few years ago. Now there are several papers, but still not enough in terms of exploration and evaluation quality of life of the patient following surgical repair in terms of nerve repair for peripheral nerve surgery. Some of the patient can have excellent or good functional recovery, useful functional recovery, but still they remain unsatisfied completely, or beyond, or the opposite. Some of the patient receive some kind of recovery, and this is some kind of recovery which is not excellent, but it's useful. It's about M3, and they remain quite satisfied in these circumstances. So this is something which is now investigating how to make a better impact and better understanding in terms of improving the quality of life of this patient. You should remember that for somebody who has nothing, a little is a lot. So when the patient has a flail arm or unable to move his hand or any muscle, some improvement remains a lot, and not to mention that if remove that this improvement is on the high level, that really have an impact to the quality of life of this patient. This is the major reason in the etiological factors of the traumatic lesion of the brachial plexus. This is not only happening in full professional sports like here with the riding this motorcycle, but generally speaking, motorcycle accidents are the major etiological factor in this traumatic brachial plexus lesion. So these are the results of outcomes of the triple nerve transfer following upper brachial plexus palsy C5, C6 reconstruction with the usage of this triple transfer, which means spinal luxatory to the suprascapular nerve and 𝒂𝒏𝒄 procedure via posterior approach, and Oberlin procedure via anterior approach. So Oberlin procedure is for the elbow flexion, and spinal luxatory to suprascapular and 𝒂𝒏𝒄 procedure is for the arm abduction. You can see excellent functional recovery. This is also in our everyday life one of the major impacts in terms of etiological factors for traumatic lesions, not only brachial plexus, but all peripheral nerves. So doing sport is very attractive. We all like to watch sports. We all like to perform some sports in terms of our recreation. But as you can see, within these sports activities, some of the major injuries can affect peripheral nerves. And then that is a question how to make this repair in terms of helping these, especially professionals, to be back in the field as sooner the better in terms of absolutely full recovery, which is needed for their activities. And these are some examples from our activities. This is radial nerve injury following orthopedic management after humeral shaft fracture during arm wrestling. And this young man received this injury following this preoperative evaluation. This case was treated by the external neurolysis, decompression, and deliberation of the radial nerve. And this kind of lesion was very grateful for the useful functional recovery. So he recovered 7 months after surgery in terms of practically complete functional recovery of his wrist extension. Similar situation with peroneal nerve. This is a peroneal nerve injury due to the knee dislocation following Thailand box performance, and this was severe knee dislocation 9 months earlier with extensive left peroneal nerve injury with 15 centimeters long nerve defect. This was not possible to repair in terms of nerve repair, direct nerve repair, or any kind of nerve grafting or transfer, but the possibility to help this patient was the usage of procedure, which is two-tail tendon transfer, and this is 5 months after surgery. He is still recovering. There is a significant recovery, and the patient is satisfied. He is capable of running. This is one special case I am presenting here with the courtesy of Dr. Jorge Clifton from Guadalajara, who is my very close friend. He was in the arena when this matador was injured by the bull. This was an open lesion of the peroneal nerve in the knee level, and he immediately went to the hospital with this patient and operated this patient in terms of making a nerve direct repair and in the same stage two-tail tendon transfer. And you can see here this matador is back to the field 2 years after injury in a full capacity. Occupational or workplace injuries are also one of the very common physiological factors in terms of affecting quality of life with either many associated injuries or isolated peripheral nerve injuries, but this happens every day. So this is a case of upper brachial plexus palsy following a workplace accident after heavy object crashing on his head and neck. He initially had a total brachial plexus palsy, which recovered up to upper brachial plexus palsy C5, C6, and he was treated multidisciplinary by the orthopedic surgeon, vascular surgeon, and myself because of these associated injuries. In this case, I perform usage of the viable C5 route in terms of grafting of the C5 and axillary and musculocutaneous nerve with usage of the medial cutaneous antebrachial nerve with a long nerve grafts up to 10 centimeter, fixation of the clavicle, and this was reconstruction of the subclavian artery. And this patient recovered quite good. Elbow flexion excellent, arm abduction up to M3, M4, but he was completely satisfied and back to do the work. And this is one of the patients we published in neurosurgery in terms of usage of the viable C5 and C6 roots, proximal stumps in the reconstructive surgery of the brachial plexus lesion. This is one of the very, very let's say, educational or instructional cases. This is something which on the first place when this patient was injured was it was looking that this was irreparable injury, but following the emergency reconstruction of the axillary artery in regional medical center, this patient was transferred to my department, and it was a circular chainsaw injury through the axilla, and this was practically flailed arm because all terminal branches of the brachial plexus was damaged. And after preoperative evaluation and within the multidisciplinary approach, this patient was treated with the reconstruction of the musculocutaneous nerve, medial nerve, ulnar nerve, and radial nerve branch for triceps with a long nerve graft. And this is practically 2 years after surgery, shows what how much is persistence in physical therapy after surgery is important for the full or the best possible recovery in this patient. So this patient is absolutely satisfied and not satisfied. Practically his arm is practically in a normal function. This is also pathology, what we are doing. This is treatment of the pain following the amputation of the limb or part of the limb. So this is a left wrist disarticulation following circular chainsaw accident. Patient suffered from the severe pain, which was by the visual analysis called verified to be 10, and then resistant to medicaments. Then following the preoperative evaluation, this patient was treated with the central anastomosis and removal of the neuroma. And 10 days after surgery, he was able to work. 6 months after surgery, significant recovery with diminishing of the pain and visual activity scale was 3, and he is able to play his drums with his prosthesis. You know that this is everyday practice practically in several regions in the world nowadays. Unfortunately, we have a lot of experience in the wartime or missile peripheral nerve injuries of all aspects. In former Yugoslavia, there was a war in the beginning of the 90s with a lot of patients with a lot of experience. This, fortunately, nowadays we don't have a wartime missile injuries, but in some situations, such was missile mass shooting in elementary school in Belgrade and one village as a back-to-back event last year, several people was injured, and these were missile injuries of the radial nerve, and 2 cases with missile injury of the sciatic nerve, with procedures such as cable grafting, and then split repair, and internal nerve lysis procedure for treatment this kind of lesion. Of course, intraoperative neurophysiological monitoring is mandatory in this situation. This is my scrub nurse. This is another pathology. This is entrapment. This is, you can say, this is easy pathology, because this is something which is predicted that every resident has to perform routinely during his residency program. This is deliberation of the ulnar nerve in the elbow level within the cubital tunnel. So this cubital tunnel syndrome, if it's not operated correctly, can produce huge problems in the functioning of the patient. So you have to explore the nerve and deliberate in all 5 sites of compression properly. And my scrub nurse, after surgery, was very satisfied, although she was hiding from me that she suffering from this problem. Another very important pathology are tumors. Tumors in the field of peripheral neurosurgery can be, like in every other field, benign and malignant. Benign schwannomas, usually you can remove radically, but this point is that in some situations these tumors can be very big and also very adjusted to the all adherent to the all other nerve structures, and you have to remove this kind of tumor and to preserve the function of the patient, which is usually intact, to the preoperative level. This is a simple case which I want to present because of the importance of the quality of life. This young lady was operated. I was operated this young lady because of the ulnar nerve schwannoma in the elbow level. So this was a radical removal and preservation of all elements with microsurgical technique. But this is also very important to understand that these people, for example, use their hands as professionals. So this is her concerto 4 months after surgery. He invited me to come. I was not able, but she sent me this video. So now coming to the let's say what is nowadays present as an practically innovation from one side, but almost implemented in regular activities in centers where this can be afforded. These are endoscopic procedures in peripheral neurosurgery. So endoscopic procedures are routinely performed for entrapment syndrome such as carpal tunnel and cubital tunnel syndrome, but also nowadays you can do with endoscopic equipment and the procedures you can do supra and infra clavicular brachial plexus dissection, and you can see quite good brachial plexus topography during this endoscopic dissection. And some kind of procedures can be also performed. This is not, let's say, in full capacity equal to the open surgical procedures, especially in the reconstruction of the complex brachial plexus lesions, but generally it's in everyday practice. Exoscope implementation in peripheral neurosurgery is now full power ongoing, and this is something which is also very useful. It is implementing like in every other field of neurosurgery, and they have some ergonomic benefits. We use exoscopes. I use exoscope also, but microscope is still predominant in everyday activities. But this is something which is future. This is also within the innovation and research nowadays developed and still developing in full power in terms that you can visualize nerve elements practically nowadays in not only morphologically, but you can visualize in terms of intraneural systematization and topography, even to follow regeneration of the axons in some situations. Of course, if you have this kind of machines, so DTI measurements and fiber tractography in peripheral neurosurgery is now also present in special centers, but still developing and improving in terms of innovation and research. Now we are coming to the one situation which we are facing regularly. So we need a precision in our activities. We need a precision in terms of our surgeries, surgical procedures, and we are doing very precise as surgeons. But nowadays, this is something which is following brain-machine interface, artificial intelligence, and all other aspects of innovation and research, which is ongoing. Nowadays, you have also very precise machines who can do practically a lot of things, and this is a question for the future. Robotics in peripheral neurosurgery is also nowadays in everyday practice, still improving. This Da Vinci system in robotic surgery is already implementing in some of the centers for the peripheral nerve repair, and these are some of the results of Oberlin and Somsak procedure from Brazilian group of peripheral neurosurgeons in terms of presenting series of patients which were successfully treated with this kind of procedure. But you see here something which is practically very new. This is MMI Simani surgical system, which is completely devoted to the microsurgery, vascular and nerve microsurgery, and this enable tremor reduction and motion scaling for the surgeons in the terms of providing the best possible surgical anastomosis. So education in peripheral neurosurgery remain within the steep learning curve from basic through advanced to the complex pathology in peripheral neurosurgery, but it's worth doing it. And in terms of education nowadays, you can have as well as innovation and research on the level this type of education, which is 3D anatomy, hands-on models, cadaver-free education, and something which is helpful to understand this. In my opinion, still you need to be in the field and to work within the cadavers and then in the OR. But generally speaking, today you can have you have a lot of possibilities for this kind of training. Coming to the point of this presentation, these are the factors that limit successful peripheral nerve regeneration. And this is something on which level is focused all practically nowadays work in terms of innovation research, in terms of to enable that this kind of problems diminished or eliminated. So factors that limit successful peripheral nerve regeneration are older age. So older patient, you can not expect quite a good recovery, especially in the older age, which means 70, 80 and beyond. But the generalists think lack of neurotrophic factors and some of activities which are ongoing in these circumstances to improve this lack of neurotrophic factors are now in terms of focus of innovation and research. Time elapsed since the injury and long distance to the target organ. This is another very important factor that limits successful peripheral nerve regeneration. So this is also in the focus of improving this that you can provide to the patient late surgical procedures in terms of later than 12 months and after injury, and to treat the longer distance in terms of nerve gaps to the target organ. Larger defects leading to the misdirection of nerve fibers. And this is something what I was talking on the beginning. This is maybe the major challenge in this field in terms of how we can impact on a molecular biology level and make this regeneration more precise and faster. Regularly, speed of the regeneration of the regenerating axon is 1 millimeter of the day, on day. These are some factors that are promoting misdirection, anatomical, morphological, intraneural factors that are promoting misdirection of regenerative fibers. And this is something what is now taking care that in the surgical procedure adapt and adjust to avoid these kind of factors. And experimental strategies for peripheral nerve regenerations are now focused on the level of neuronal growth, site of nerve injury, and the target organ. And on this level, pharmacotherapy, cellular therapy, tissue engineering, advanced biomaterials, physical therapy, gene therapy are in everyday practice. These are some of the strategies for impacting them on the molecular level. Stem cells, gene therapy, augmenting nerve regeneration with electrical stimulation, phototherapy. Coming to the artificial nerve grafts, which are now can be designed with the 3D printing strategies, with different materials and functional cues. This is also now evaluating through the different stages of the experimental laboratory and clinical implementation level. This is something what we are doing in Belgrade in terms of implementing artificial nerve grafts in making an experimental 3D printing and putting in a femoral static nerve repair in rats, for example, and trying to explore how this can improve the regeneration of the axons. And this is the main question. Will it be possible artificial nerve 3D printing to make this kind of artificial nerve to avoid usage of the simple grafts such as auto transplants in terms of avoiding this as a regular practice. This is from Japan, and this is something which is very important in terms of improving the quality of life of the patients with irreparable nerve lesions. This is thanks to the Professor Yoshiyuki Sakai, who is coming in Belgrade within 3 weeks to present this CyberDin technology and exoskeleton for the patients which are let's say in terms of paraparesis or paralyzed and in the wheelchair. Artificial intelligence is in everyday practice, so this is thanks to these abilities we can use this to improve the quality of life of our patients. So these are the facts and myths which are already boosted in terms of importance of peripheral nerve surgery and quality of life for the patients. Still nowadays we are on the level that in terms of coin flip situation-based decision making as a matter of intraoperative finding and surgical experience, and the class 1 evidence between class 1 evidence based on a preoperative evaluation for the decision-making process tailored to each individual patient. Nowadays, still there are no enough class 1 evidence based on the preoperative evaluation, and this is something what is also working on. So top 10 reasons why neurosurgeons should do peripheral neurosurgery is: 1, this is neurosurgery; 2, this is you have to have knowledge of neuroscience. Handling the nervous tissue, you have to have microsurgical skills. Possibilities for education and research are high. Steep learning curve is of course present, but worth doing. Lot of possibility for innovation. Results are good, and you can improve the quality of life of your patient. And you have a lot of opportunities and possibilities to work on this. Top 10 problems in peripheral nerve surgery which are still remain for improvement are late reanimation, facial reanimation, vocal cord treatment of the vocal cord paralysis, treatment of the keratopathy, to do or not to do frozen section to confirm viability of the proximal stump, to improve nerve transfer, and to solve some rare pathologies such as anterior cutaneous nerve entrapment syndrome, tumors to treat the pain such as in rare symptoms such as meralgia paresthetica, clunal nerve neuralgia, pudendal nerve neuralgia, and augmentation of nerve regeneration. So in conclusion, none of the nerves will recover the same. And as I said, class 1 evidence based strategy or strategies development are still matter of further double-blind randomized cohort multicentric control studies. Surgeon decision based on knowledge and experience is still predominant impact factor, and hand of the surgeon remain irreplaceable factor despite how the world would like in 21st century. And this is the essence of the peripheral nerve surgery. Keep it simple, surgeon. You should cover simply your clinical history and exam. Keep the indication for surgery simple. Make the surgery simple. Nerve surgery can be done with the simple basic instruments. And if you have complication, you have to accept and deal with this. These are the tasks that the few devoted group of the few devoted neurosurgeons from all worldwide put on their portfolio for everyday activities in terms of improving the interest and raising an awareness and full education in peripheral neurosurgery, either on site in terms of going to some country, some institution where is peripheral neurosurgery developing, or accepting fellows from different parts of the world in our departments for education, and with a large armamentarium of online education activities such as this one. So keep calm, raise awareness, and love brachial plexus surgery. And may the force be with us, with all of us, in terms of handling the everyday activities within the future progress and development. This is something what is ongoing. I would cordially like to invite all of you to the series of activities in Southeast Europe region, starting from next week, October 9 to 11, in the Budapest 6 Congress of Southeast European Neurosurgical Society, major European educational event this year, European Association of Neurosurgical Societies 2024 Congress in Sofia on October 13 to 17. And then 10 Serbian Neurosurgical Society annual meeting with international participation, which is completely devoted to pediatric neurosurgery in the 21st century challenges and opportunities. This is my mentor, Professor Miroslav Samardžić, whose merit in making Belgrade visible as a center of excellence in peripheral neurosurgery is of outstanding importance, and this is something what I really would like to thank him for his outstanding support always. So that's all, folks. Thank you for your understanding, and thank you for this possibility to give me this opportunity to speak with this. And I hope to see you soon in Belgrade or somewhere around the world. Thank you.
Thank you, Professor Rasulic, for this wonderful presentation. I must say that peripheral nerve surgery is always very fascinating because it requires a very deep understanding of anatomy, not only of the nerves, but also muscles and bones. So it's really amazing surgery. And also, as you mentioned, actually, it often requires similar skills which are required for vascular neurosurgery, for example. So it's a very demanding surgery. I would like to open the discussion now, and I kindly ask our discussant, Professor Ashish Kumar, to give his comments. Thank you, Ashish.
Thanks, Alberto. Professor Rasulic, this was a little bit out of my area of expertise, but I could see how like the peripheral nerve surgery domain has evolved. There are a couple of surgeons in the city of Toronto who are doing this, and we all actually are referring our patients with, for example, malignant peripheral nerve sheath tumors, or if someone has a neurofibromatosis. So I wanted to ask if, because I think there is, the team received a $1 million grant for research on neurofibromatosis. Do you have an experience in terms of neurofibromatosis and the role of peripheral nerve surgery if suppose somebody has multiple peripheral nerve sheath tumors, and how to manage them and how to follow them over their lifetime in terms of clinical follow-up?
Thank you for this question. This is a very important question. Simple answer would be if it is multiple even schwannomas, not to mention multiple neurofibromas, if the patient has not symptoms, you don't treat them. You don't operate them. If some symptoms appear, depending on the type of the symptoms and the acceptance of the patient, awareness that what is necessary to be done in terms of eliminating these tumors, especially in terms that all these patients have an intact neurological status. Their function is usually intact. And then when you manipulate even if it is a so-called simple schwannoma, some manipulation can result in a transitional deficit. And this is something that patient has to know in advance. But in terms, if it is a plexiform neurofibroma, which is progressing and developing and making symptoms, in terms of radical removal of this, you have to resect this part of the tumor, of the nerve, and to resect it radically to have a free resection line and that remains after that some nerve gap, which can be in some situation very long. But we are always doing immediate nerve repair in terms of grafting after this, if we have this kind of situation. But in case what you make a question, first rule is do not touch if there are no symptoms. I hope you are satisfied.
Yes, thank you. In terms of the vestibular schwannoma surgeries, I know you mentioned that facial reanimation is still a challenge, and we still have few patients with vestibular schwannoma surgery with facial nerve paralysis, and if it's grade 1 or grade 6, that's a different matter. I wanted to ask, like, why facial reanimation has not picked up, and why do you think it's a challenge? Because I think there is a huge need for patients who have facial nerve deficits after the vestibular schwannoma surgeries.
Simple answer is it's not any challenge if you catch this patient and treat him properly on time. Usually, these patients are coming too late because this kind of lesion are usually treated, which is not correct. Usually treated even with on the high level centers with the possibility of high level preoperative or diagnosis in general. These lesions are not recognized on time, and generally speaking, when you have a delay of some more than 6 months, or then you have this kind of challenge how to make a reinnervation of this to improve the regeneration of the facial nerve. Otherwise, if you catch it, for example, if you reconstruct facial nerve in the pontocerebral angle, if you catch this after following during schwannoma surgery and make either direct suturing or grafting of the facial nerve in the pontocerebral angle, you can expect good recovery. If you have some kind of injury, any type of injury of the facial nerve on the peripheral part of the facial nerve, if you catch it on time and make exploration and make adequate repair, you can expect very good recovery. And that's it.
Thank you so much. So the ideal time for someone to, for example, if it is not recognized intraoperatively and there is, and you identify in follow-up. So the ideal time within 3 months of surgery is the ideal time for any kind of facial reanimation procedure, or the earlier the better?
Ideal time is up to 3 months.
Up to 3 months.
It's ideal. And the optimal timing is from 3 to 6 months. After that, you can expect also good recovery, but the later renovation makes this situation more challenging.
Thank you so much. Thanks for your fascinating lecture.
Thank you.
Thank you, Ashish. And I see Dr. Sukirti raised her hand. Please, Sukirti.
Yeah, thank you, Professor. It was an excellent lecture. Well, I will tell you regarding my experience, I have done a few cases of nerve repair, and the results were not encouraging. So what happened, like you said, is that we got discouraged, and then I prefer not to operate or not to go ahead with the cases. Is it like I selected the wrong cases, or because your results are so good, I'm enticed to do it again? So am I selecting the wrong cases, or what is wrong? Like I felt discouraged. I did 2-3 nerve repairs, and they didn't. It was like I felt that it's just due to regeneration and not due to my surgery. That's how I felt. There was like 10-20% improvement. That's it.
I didn't hear from the beginning what type of cases you mentioned.
One was median nerve repair, and one was ulnar nerve repair with the orthopedics. With the orthopedics, they had a trauma case, and the nerve was severed. I did a microscopic repair, but the results were not so good. They were there, but not so good. So
you mean I didn't hear again brachial plexus lesion or some other type of lesion?
No brachial plexus, or the peripheral nerve in the forearm.
Which type of nerve? Which type? Upper arm or lower arm?
One we did in the upper near the radial, and one we did in the hand. One was radial and one was in hand. So both were like 20% improvement, sensation improved, patient had paresthesia. So is it positive thing due to surgery or is it regeneration? I had a doubt on my own surgery after that.
There are several factors that can influence on the final outcome in such situation. One of them we mentioned, this is timing. I don't know the timing of your surgical procedure. Another one is type of the surgical procedure and length of the nerve defect. And third one is continuous physical therapy after surgery.
We did that.
These are three major impact factors which can have a impact on a final outcome. Of course, type of the nerve and the level of the lesion is also very important. So high proximal or high distal lesions, you can always expect there will be some kind of let's say not excellent or not good, but useful functional recovery. And in some situation, you can have a useful functional recovery, but generally speaking, high level and low level, I mean, extremely high and extremely distal lesions are not very, let's say, grateful for this reconstruction. But if you are talking about the hand, if you do it in terms of adequate microsurgical procedure on time, this can be then with the continuous physical therapy, you can expect good results.
Okay, and no
matter if you have one case or two cases that they didn't recover well. If you have 20 or 40 or 100 cases, you will see that 80% of them will recover.
Okay. So what about the paresthesia and the burning sensation patient feels after the surgery? Is it like I felt I didn't know, I then gave the patient gabapentin and melatonin, that is what is written in the books. Do you have any magic medicine for that?
That is also depend on the each individual situation. I mean, they are not patients are not have regularly this kind of sensations and symptoms following surgeries. In some situation, yes, but regularly no, because the nerve is damaged. Nerve is there is no conduction through the nerve which is damaged. So this kind of sensation can be, let's say, maybe in some failed entrapment syndrome surgeries, or in some kind of let's say traumatic injuries, but this is usually together with the severe pain. But only paresthesias are not so frequent in this situation.
Okay. And sir, after doing the surgery, do you wrap it up with a muscle around it, or do you do something like that so that there is no fibrosis at the site of suturing?
There are some procedures that can be done in this situation. If you don't have these artificial conduits, which are now practically very frequently used in this situation, you can put some part of the vein or some part of the adipose tissue around this, but usually people are doing this, but I'm not. I usually put my suture lines either one or two, if there is direct or grafting procedure, put some fibrin glue around the suture line in terms of making a protection and stabilization of the suture line, and put this in the, let's say, in the anatomical layer, which is adequate for the situation, and that's it.
Thank you so much, sir. Thank you.
Thank you. And Ishu?
Yeah. So thank you so much for this wonderful talk. And Professor, I am doing brachial plexus and peripheral nerve surgeries regularly for the last 5-6 years. I have one question, like whenever, how do you decide when to do only neurolysis, like based on your pre-operative workup? Like if patient is having nerve deficit, usual plan is to repair the nerve, but you said that doing neurolysis, it gives better results because there are some potentials already there and you release the nerve. So when to do only neurolysis and when to do nerve transfer, because patient is coming with the deficit.
Yeah, okay. Thank you for the question. This is also clear because if you have to have some kind of reliable preoperative evaluation. This is especially related to the nerve conduction studies, and then to the neuroimaging procedures. So following this, you can see it, and of course, in correlation with the clinical findings. So if you see all of this in the terms of making a diagnosis, you have this, you have a 92% of specificity and sensitivity to expect something what you can do in the surgery, and this the rest 8% you are let's say completing within the surgery intraoperatively, and you have to have intraoperative neurophysiological monitoring. This is ideal scenario. If you don't have all of this, you can rely on your experience, but also in correlation with clinical findings. Clinical findings are most important issue. And finally, in some cases where this is clear that patient has an avulsion, there is no need for discussion about neurolysis. Then neurolysis is not helpful in this situation. You have to do nerve transfer. But when there is no sign of avulsion and there is a lesion in continuity, and then you have for final check, you have to have direct stimulation. You understand me?
Yeah.
Patient not relaxed in anesthesia.
Yeah.
And you have to have direct stimulation of each individual targeted nerve. And if you have some muscle contraction or muscle response in this situation, direct stimulation of the nerve, not muscle, of the nerve, which you are repairing. If you have, and finally, you have a 2-hook, 3-hook intraoperative neurophysiological monitoring. With usage of this, you are checking the conduction on the particular segment of the nerve. So after this, you are making a decision. If you have some kind of contraction, if there are some conduction, you are doing neurolysis. If there are clear signs of avulsion, no response on direct stimulation, no response on the intraoperative neurophysiological monitoring, then you are doing nerve transfers depending on the situation.
Thank you, Professor. Then my next question is like, if a patient is coming to you with some kind of deficit and his nerve conduction studies, they are showing some positive potentials in the damaged nerve. So do you go for the neurolysis in that case or leave it with physiotherapy and natural course to recover?
Can you repeat the question once again, please, from the beginning?
Yeah, Professor, like if a patient is coming with some deficit and the nerve conduction studies, they are showing some potential in the damaged nerve, but patient is having deficit. So do you go for neurolysis in this case, or you advise him physiotherapy and natural course so that with time he or she recovers? So like,
so that depends, that depends on the timing of and the type of injury and clinical findings in terms of any kind of spontaneous recovery. So if the let's say lesion is within 1 month and there are some there are paresis or paralysis or functional deficit, and then there are some sign of nerve conduction, I will wait in terms of monthly evaluation for a few months, but following monthly this patient in terms of there are some progress in their spontaneous recovery or not. Or if there are some progress in recovery, spontaneous recovery, if this recovery is going anatomically, or there is some kind of dissociative or non-anatomical recovery, this is also indication for surgery. So this is something also related within the monthly follow-up clinically and electrophysiologically in terms of few months after injury. But if the patient come to me let's say 6-7 months after injury and has some this kind of let's say situation, I would recommend surgery. I mean, not as an emergency, but sooner the better.
Okay, and when do you avoid doing surgery in such kind of cases? Like after how many months you leave it? Like
No. This is not related to the months. This is related to the clinical science and correlation of the clinical science and the electrophysiological studies in terms of spontaneous recovery. If you see that this is a regular spontaneous recovery which is ongoing and improving, and this is confirmed by the conduction studies, fine. Then you are following this patient up to 6 months, and then after that, you ask him to come for some checkup within the 3 months, and during the 1 year, he's out. He's either surgery free, which means there is no need for surgery, or he's between these 6 months already candidates for surgery, and you are operating.
Professor, one more question. The thing is that, like, one of my patient, I did suprascapular spinal excessive nerve transfer, but the second was planned is pectoral nerve transfer to nerve to biceps. But that patient came to me after 9 months. So I dropped the idea of doing that transfer. So I was asking that in such late case, do you go for surgery or leave it? Because already the muscle was atrophied. Severely atrophied.
How old is the patient?
He was 45-year-old.
You have to do something to this patient, no matter that this is 9 months. In 9 months, this is not too late. This is late, but this is not too late. In 9 months, usually irreversible changes in terms of atrophy are not happening. This is happening between 12 to 18 months, and in some situation even up to 24 months after injury. That depends also on a physical therapy before this surgery. You understand me? Patient has to have to the physical and have to have muscle stimulation and passive movements and everything in terms of void contractions. This is also very important to this patient. If no matter that he is not recovering, but he has to go to the physical therapy in terms of keeping the muscle alive as longer as possible. In this situation, you can also make this kind of surgeries. I don't know the case, but you have if it is a C5, C7 lesion or C5T1 lesion, you have different strategies, options in terms of providing this patient. And usually we operate these patients in one stage. No matter anterior or posterior, you understand me? No two stages. So we may operate in one stage. We have combined anterior posterior approach. We are going firstly to the posterior approach, and then we are finishing with the anterior exploration of the brachial plexus or putting some kind of and that's it.
Thank you, Professor. I will try next time doing in same sitting.
Okay.
Thank you, Professor Rasulic, for the wonderful presentation and also the very active discussion. You gave us many advices, very useful for our practice. And if there are no other questions to Professor Rasulic.
Just one word to Lucas. Thank you so much, Lucas. So it was an excellent talk. I think we learned a lot, and also that we understood, because the peripheral nerve will have a very bright future, I think, including of the molecular level. So all the best for you. Thank you so much.
Yeah, thank you very much, Professor Kato. I appreciate your support and help in every situation. And you know that I'm looking forward to welcoming you in Belgrade. So you just have to come. I mean, all of you, but this especially goes to Professor Kato and open to all of you.
Yes. Thank you so much.
Thank you, Professor Kato. Thank you again, Professor Rasulic. And I now give the floor to Professor Ishu Bijnoi for the next talk for the introduction of the speaker. Thank you, Ishu.
Thank you, dear Alberto. So I would like to invite our next speaker, Dr. Jerima Omaro. He's a Kenyan neurosurgeon who was a fellow from Fujita in 2024, and he has keen interest in neurovascular skull-based surgery and spine surgery. And he has done his neurosurgery from University of Nairobi. He has done various other programs and in different kind of specialties and attended different neurosurgery conferences and workshops. Currently, he is working at the same university in Nairobi, Kenya. And today he will be talking on ventriculoatrial shunt in normal pressure hydrocephalus, a technical note. So I would like to invite Dr. Jeremy to present his presentation.
Thank you, Professor Ishu, for this wonderful opportunity. Let me share my screen. I hope my screen is visible.
Yeah.
Okay. Thank you for this wonderful opportunity. I also want to thank Professor Kato for giving me this opportunity to become a Fujita Fellow at Fujita, which I'm currently at. I still have 1 month remaining. And through Professor Kato, I've been able to observe this critical procedure that we do for elderly patients who have normal pressure hydrocephalus. And I think I developed an interest so that I'll be able to publish a paper that we can actually adopt as a protocol in our country. There's no conflict of interest for my presentation. And so as a point of introduction, normal pressure hydrocephalus is quite a devastating disease in the elderly. And so when you look at the Japanese trials and Japanese publications, they put it as a patient who has an age more than 60 years with dilated ventricles. Then on top of that, they put the Hakim's triad, which has both gait disturbance, urinary incontinence, as well as cognitive dysfunction. And so this becomes a devastating disease, especially in recent ages where more people are becoming more elderly, and this will actually present a common disease. And so as part of management of this disease is that there is CSF diversion, and different methodologies have been done, including a ventriculoperitoneal shunt, a lumboperitoneal shunt, and even a ventricular atrial shunt. Initially, people tend to believe that a lot of complications actually occurred with ventricular atrial shunts. But recent publications have noted that actually these complications are not as common as they used to be published before. And so noted in other studies is that the difference between the ventricular atrial and the ventricular peritoneal shunt is actually not so significant to bring out the difference between the two. And when I was trying to look at some of the case series in my country as well as continent, generally I noted that actually ventricular peritoneal shunts are more preferred than the ventricular atrial shunts. And so just to review of some of the studies that I went through, this was one of the studies that was published by Huang et al. And it was trying to compare ventricular atrial versus ventricular peritoneal shunt complications in patients with idiopathic normal pressure hydrocephalus. Most of the patients, as we noted, that have been were patients who had ventricular peritoneal shunts, and up to twice the population of those who had ventricular atrial shunts. You can see the age difference was not that significant, and more males than females were noted in both studies. One of the biggest noted complications was that of overdrainage, and as actually we can note that it was more common in the ventricular atrial shunts, but the rates of infection were relatively the same between the two studies. And actually, even renal complications were also noted in ventricular atrial shunt. However, the rates of shunt obstruction were more common in ventricular peritoneal shunt. And this will actually point out towards even higher rates of shunt revision in patients who had ventricular peritoneal compared to ventricular atrial shunts. This is a systematic review and analysis paper that was looking at 6 papers, and which are just looking at the complications as well as the surgical outcome of all of ventricular atrial versus ventricular peritoneal shunts. And if you look at these forest plots, like in the population in the surgical revision, we can note that the rates of surgical revisions were more in favor of ventricular atrial shunts than the ventricular peritoneal shunt. Then if we look at the rates of shunt dysfunction or shunt obstruction, Then most of the studies noted that there was more favor in ventriculoatrial shunts compared to the ventriculoperitoneal shunt. And this was actually statistically significant. Then when you look at the rate of infection between the two populations, we can note that there was no significant difference because most of the pooled statistics are within the line of no difference. And so in summary, this should point towards low risk of shunt dysfunction or obstruction within the ventriculoatrial shunts compared to ventriculoperitoneal shunts. And so in my study, I tried to look at the step-by-step procedure of ventriculoatrial shunt. And so in a way, reciprocate the same procedures in my country. And so the key steps in management of ventriculoatrial normal pressure hydrocephalus through the ventriculoatrial shunt is including that of anesthesia and patient positioning. Most of the population were put under general anesthesia and the patients were positioned supine. Then the estimation of the borehole, as that done in Fujita, was by use of magnetic neuronavigation, as you are going to see the next slide. And this would actually guide the point of puncture of the posterior horn of the lateral ventricle. And with this, then the surgeons were able to determine the position of skin incision, both cranially and in the cervical spine, where in the neck region where the atrial shunt was being put, an ultrasound was actually used to determine the level of internal jugular vein. Then there was infiltration of lignocaine adrenaline combination to reduce the rates of bleeding in both sides. Then the patients were sterilely draped and skin opening was done with a borehole done in the cranial site. And then subcutaneous tunneling was done with coupling of the shunt to prevent its dislodgement once the shunt was put in the subcutaneous area. Then dural incisions were made and ventriculocentesis was done by use of a Dandy's cannula. Then after this ventriculocentesis, then the ventricular catheter was inserted and a direct vision along the trajectory of the insertion of the Dandy's cannula. Then after that, the atrial catheter will be inserted by use of the ultrasound guidance to confirm the positioning of the catheter within the internal jugular vein. Then after this, the surgery was done and the skin incisions were closed in layers. So this is just a pictorial representation of how the valve looks like. There is the ventricular catheter, which has both the ventricular catheter and the programmable valve. The 𝑠ophister shunt is what is used most commonly. And so this is actually what controls the pressures of the shunt. So this is just a 3D CT reconstruction, just to show how the ventricular catheter is within the ventricular surface and the whole anatomy of the ventriculoatrial shunt. This is a picture that was picked up from the publication by Professor Kiyoshi Takagi, who's been instrumental in developing this technique within Japan. So I'll just present a video to show the procedure. So this is the initial scan for the patient that we had. You can see the dilatation of the frontal horns of the lateral ventricle. There's the acute angulation of the frontal horn, and there is the enlargement of the sylvian fissure. This is suggestive of the disproportionate enlargement of the subarachnoid space in patients who have a normal pressure hydrocephalus. So once confirmation of this has been done, then this is the patient's positioning. You can see how it's positioned, supine. There is a log in the ipsilateral shoulder just to elevate the ipsilateral side. Then the incision that is marked by use of magnetic neuronavigation. You can see the still station here for Medtronic. This is actually what is used and not the named positions that we usually use for insertion of shunts, like the Keen's position. So once this patient has been positioned, and this is the neuronavigation position, confirmation of the shunt position. This is the shunt that is actually coupled before being inserted with the patient and put in a solution before the incision and the surgery begins. So after this is the opening of the skin incision at the occipital region. You can see the creation of the subcutaneous hole where the valve will sit, and this is the cranial borehole done. Then the neck incision is opened, and then this is the tunneling proximal to distal, and this is the insertion of the distal shunt from distal, and it's pulled up. After that, the coupling of the shunt is done, the ventricular catheter against the atrial catheter. Then this is the neuronavigation that is actually used again after the skin incision has been made and bar hole to confirm the trajectory that you are going to use in inserting the shunt. And this is just a confirmation of that. Then this is the ventriculocentesis that is done with the cannula. And once this has been measured, as you can see, anterior to it, there is a layer of bone cement that is used to measure the distance that the cannulation was done, and this will actually be reciprocated with the ventricular catheter that is inserted. So that has been done, and confirmation of the shunt CSF confirmed. So this is the insertion of the ventricular catheter along the same trajectory. So once this is done, the valve is palpated to confirm CSF drainage from the distal aspect. And now we come next to the neck incision and determination of the level of the internal jugular vein. And that is confirmation from the ultrasound. You can see the collapsible internal jugular vein against the internal carotid artery, that is the carotid artery, which is actually more round and incompressible. So that is how we confirm, and the cannulation of the internal jugular vein is done under ultrasound guidance. After that, there is insertion of the ventricular catheter. There is a guide to insert, and then, as you can see, this peel-away catheter that is used, this has actually enhanced the insertion of this catheter, because once the catheter, this peel-away catheter is positioned inside the internal jugular vein, it's actually peeled off, and the atrial catheter that is put within this catheter is left in situ within the internal jugular vein. So this is the surgeon inserting the atrial catheter. And after confirmation, you can see how the catheter is being peeled away, and you are left with the atrial catheter within the internal jugular vein. And with that, we can see that the surgery is now over, and now the skin incision are closed both within the cranial site and within the neck region. So with this is the final surgery, and you can see the short distance from the cranial site to the neck. This is one of the big advantages of this compared to the ventriculoperitoneal shunt, that you actually have to go across the neck, across the anterior part of the chest to the peritoneal cavity and insert the catheter there. That long trajectory actually is associated with significant pain for patients postoperatively. But because of this small surgical site, then patients tend to get marked relief postoperative without significant complications. So what are some of the advantages of this VA shunt? You can see the narrow surgical field that was put that the patient undergoes. So this actually makes improvement of the patient postoperatively significant. It is a less invasive surgery. You can see the inherent use of the neuronavigation and use of the ultrasound makes us put significantly short, smaller incisions, both cranially and along the neck. And this has actually been done in other centers under local anesthesia. Then, because of patients who have obesity, patients with constipation, abdominal distension, then they tend to get high rates of shunt failure because of the difference between the pressures from the cranial and the abdominal. And these varied pressure differences actually might contribute more towards shunt failure. And so you can see that because this catheter is put directly into the superior vena cava or into the right atrium, there's no significant pressure difference between the superior vena cava, and they're usually more or less stable pressures. And so the rates of failure for patients who have ventricular atrial shunts are much lower than those patients who are put under ventricular peritoneal shunt. So one other advantage is for patients who undergo lumboperitoneal shunts, because sometimes some of these patients tend to have lumbar spine disease. So you do not want to put a shunt within the same area that probably in future the patients might undergo surgery, and this will actually affect the position of the shunt and will probably need to be revised. So because we are putting it within the right atrium, then these patients who have lumbar disease can actually undergo the same surgery without significant changes within the shunt. And so in summary, what I want to say is that ventricular atrial shunt is an alternative primary treatment option for patients who have normal pressure hydrocephalus. We need to develop standardized protocols in our centers for insertion, and these protocols can actually be developed or use the protocols that are there to implement this ventricular atrial shunt. The complications that were actually reported earlier in prior studies have significantly reduced in recent studies, and those studies even done by Professor Kiyoshi has proven that actually he has not had any of these complications in his studies. And so probably these are some of the myths that were there before that probably are not there in recent times. So this is a publication by Professor Takagi. He's a professor from Japan. The far right of this picture that was taken during the hydrocephalus conference that was done around 2 weeks ago here in Nagoya. And this publication was given to me by Professor Yoko Kato, and it actually helped me in preparing this presentation and actually understanding this important technique that can actually be done in our country. Professor Gotani, also who comes from France, is actually a great proponent of ventricular atrial shunt, and from his studies, it's actually proven that ventricular atrial shunts are actually more successful, and he's one of those surgeons who actually do this procedure under local anesthesia and in day case, and patients are actually discharged within the same day or the following day. And so with this, I finish my presentation, and I want to thank ANS for giving me this opportunity to present my case. Thank you very much.
Thank you. Thank you, Dr. Jeremy, for this wonderful presentation. So now the house is open for the discussion. So I would like to invite Dr. Ashish Kumar to give his comments, please.
Thank you, Ishu. Great presentation, Jeremy. I actually, in my practice, do a lot of shunts for normal pressure hydrocephalus. I know you showed a systematic review and meta-analysis where the VA shunts were actually better in terms of the complication rates associated with shunt malfunction. But in terms of usual practice, we usually normally we keep ventricular peritoneal shunt as our first option, and VA shunts for example, somebody has peritonitis, somebody has a shunt infection, or for revision cases, VA shunts are preferred in our practice. But in that paper, do you think with VA shunts directly or as a first option is a better option for longevity of the shunt, and if it causes based on what you have seen, if it causes less rates of shunt malfunction or obstruction or infection or shunt migration, for example?
So what I've been able to experience in Fujita, because this is my first time experiencing atrial shunt. Actually, I think from the studies, from the population of patients that they have been able to do here, they have not reported any rates of shunt dysfunction or shunt dislodgement from Fujita. And so this is actually why it is actually the first procedure that is done for patients who have normal pressure hydrocephalus. From the systematic review, they didn't look more towards those cases of shunt dislodgement. They just looked at rates of shunt dysfunction and shunt obstruction. And that is why they were able to prove that actually VA shunts are actually having less chances of shunt obstruction compared to ventricular peritoneal shunt. But this is actually an area of study that can be done within Fujita to be able to see if there are significant failure rates within the ventricular atrial shunts. Thank you.
Thank you. Also, in terms of the site of entry, do you directly go into internal jugular vein, or you try to see external jugular vein as a conduit? or all the patients are directly into the internal jugular vein?
So all the patients here I've seen, they're all directly put into the internal jugular vein by use of the ultrasound to confirm within the two heads of the sternocleidomastoid. They're able to identify the internal jugular vein using the ultrasound, and from there, it's able to be cannulated. So that's what I've been able to experience here in Fujit.
Yeah, thank you. And lastly, I will ask, like, in terms of the shunt which you use, was it a programmable valve? Because for NPH patients, they need a lot of fine tuning about the the pressure or the pressure gradient you want to set up for drainage. Did they use programmable valve for VA shunts?
Yes. Here they use the
Okay.
program shunt, the 𝑠ophiSA shunt to be specific.
Okay, thank you.
I would just like to give a small comment and help out to Dr. Ashish Kumar with some information. The thing is, during my experience in Fujita, I saw a lot of these VA shunts, and what I felt was like it is a lot more technological dependent also in terms of the kind of shunt and the infra we use. Okay, and when you are being trained as a neurosurgeon, then most of us in our country, we are like post general surgery. For us, VP shunt appears a little more easier. So it's basically because of the kind of training we have. And second, other thing is with reference to complications, the question which you had asked, in terms of complications, much more easier for us to manage the VP shunt complications. That's what I felt, because during my tenure in government college, we had a lot of complications. I did a study on the complications of VP shunt actually. So there was no mortality. That's what I can say. So and in terms of VA shunt, honestly speaking, if I think of complications, then it becomes really difficult to manage. And it's being done in the best of hands. So yeah, no complications there. That's what I would like to add.
Thank you. We also thought like the same, but I think the practice and the surgeon experience also probably is the reason why they're using VA shunts as a first choice. And I think most of our patients are mainly post-infectious, so we'll be probably trying to avoid putting in post-infectious hydrocephalus. But here it's for NPH, so I think that's why it's been working so well. So it's good to see like it being used as a first-hand option for shunting. Thank you.
Dr. Firdaus?
Hello, Jeremy.
Hi, Dr. Firdaus.
Hello. Hey, how are you? Nice to see you again. You have given a nice presentation, and I have one question that you may go through numerous papers and literatures about VA shunt. I hope already. So do you find any association between hemolytic anemia and VA shunt?
So from the studies I've seen, I have not been able to see any connection between hemolytic anemia and VA shunts. This is an area I'll probably want to look at and see if there's any relation. But I've not been able to see any correlation between the two.
Thank you.
Thank you.
Yeah, Dr. Yu.
Hello, everyone. I have one question for Professor Kato and everyone for the obstructive hydrocephalus, for some cases with the tumor of the third ventricles or a narrow peduncular space, we can't do the EPD for the patients. So for syringomelia, we can do the syringo subarachnoid space shunts. So why can't we do that for cases with tumors within the third ventricles, like we do the ventricular subarachnoid shunt? Do you think it's possible?
Good question.
This is my idea. I searched on the internet, but the field literature.
Dr. Pham, can you repeat your question?
Yeah, for the syringomyelia, they can do the searing separate noise shunt, right? But for the brain, for some obstructive hydrocephalus, that for the cases that we can't do the EVD, can we do the ventricular separate noise shunt?
He's saying that putting the shunt in the ventricle and leaving it in the subarachnoid space so that there is bypass
within the brain. So
lamina terminalis, just like doing endoscopic third ventriculostomy.
Yeah, like that. But for cases with like third ventricle tumors, like narrow hypothalamic space, we can't do that EVD. And do you think that we can do that?
Hypothetically, it is possible. Theoretically, I don't know.
So I think
I don't know.
Hypothetically, I feel, see, both of them are in the same pressure chamber. That is the brain. But when you are diverting it to the ventricle or when you're diverting it to the peritoneum, there's a pressure change. So that increased ICP due to the tumor, that is the one which is pushing the CSF out of the brain. But when you're assuming that we do a shunt between the ventricle and the subarachnoid space, both the spaces are in pressure. That we need to keep in mind in a tumor case. So according to me, it'll still a ventriculoperitoneal shunt is better than a ventricular subarachnoid, whatever, the other shunt, subarachnoid space shunt, which you imagined.
Yeah, like that is keeping the Monro-Calried doctrine in ventricular subarachnoid shunt, that will remain same.
Yeah, exactly.
It is always there in this closed compartment, whether you are putting the CSF in the ventricle or leaving it in the subarachnoid space. But if you are doing ventriculoperitoneal or different kind of shunt, you are taking away that CSF to some other cavity and releasing the pressure. That was the answer.
I mean, for the obstructive hydrocephalus.
Yeah, but you did get the point. Like
the concept is both are pressure chamber, both are in the same pressure chamber. That is the skull. One has to go out.
Yeah, I mean, in case of obstructive hydrocephalus, there might not any problem with the absorption. So
yeah, I think your question is related to what's the etiology, right? Like ETB works in obstruction because it bypasses the obstruction point. And similarly, if you have a reason where you think there is, I think ETB does not work in communicating hydrocephalus because there's a problem in absorption, as you are saying. So if there is a problem where you think there is a physical obstruction, you can bypass it. I don't think so it will be a problem as long as it gets absorbed in the venous system, right? I think that's what you're trying to make. And that's the same principle on which ETB works for obstructive hydrocephalus and does not work for communicating hydrocephalus. And as well as, like, obviously VP shunt works better in terms of because you add gravity and absorption. It's better.
Yes.
But there is
avoid the complications.
Yeah, I know, but you have to be using it for only obstructive hydrocephalus, right? Like that's why you can bypass it within the subarachnoid space, like ETB.
Yeah.
So it's very rarely, like most of these indications, especially for NPH, it is communicating one. But I just want to mention there is a new interventional technique. I don't know if everyone has heard about it, but it's a technique of using an evascular shunt where now, I mean, it's very early and it's been devised by Professor Lilik. And he's from Argentina, and it's going into human trials where they actually try to use a shunt which goes through the venous system. And they actually penetrate the perimesencephalic cistern, and the shunt goes through. It has a sharp point and its sharp tip, which penetrates through the venous system into the subarachnoid space at the base of the skull. So it's a very short device which goes from the vein, internal jugular vein, and go up, and it penetrates the subarachnoid space. It's still very early, but I think there are a lot of centers in US which are recruiting patients for that. So that's an endovascular option for NPH. And I'll probably share the link after the webinar. It has been presented in neurointerventional meetings
yes, we heard before.
Yeah.
Yes,
Yes. So it's a good alternative, but
yes.
it's too early to see the final outcome.
But maybe Dr. Hugh, he knows about that paper. Thank you very much. But I think I never heard that such a system. But I think it's very ideal one. Theoretically, it's okay. Thanks.
Thank you.
Yeah, thank you, everyone.
Dr. Hugh, you have creative mind. Keep it up.
We can make a clinical trial. Yes.
Yes, you can do it.
Yeah. You can have a Professor Rebecca.
Okay.
So are there any more questions or comments? So, now we can move on to the Dr. Sogo Yoshikawa. So I would like to invite you for your training during your 6-month trip around the world. So you can introduce yourself and tell us about your experience. So please.
Hello, everyone. Nice to meet you. My name is Shogo Yoshikawa. I'm a neurosurgical resident at Nagoya University. Today, I'd like to talk about my fellowship experience around the world. And wait. Sorry, wait. I'm. Hello, can you see it?
Yeah.
Okay, thank you. Today, I'd like to talk about my long fellowship trip experience around the world. And I was born in 1997 at Bantane Hospital and grew up locally and enrolled at Nagoya University. I was inspired to pursue neurosurgery after Professor Kato treated my grandfathers at trigeminal neuralgia. After completing 2 years of internship and resident training, I decided to undertake a half-year fellowship abroad before studying as a neurosurgery resident. Currently, I'm working as a neurosurgery resident at Toyota Kosei Hospital, where I originally trained. Over 6 months, I visited 6 facilities in 5 different countries. The first destination was the University of Verona in Italy. It's a beautiful city famous for Romeo and Juliet with a population approximately 250,000. Under the guidance of Professor Albert, I trained alongside many resident colleagues and learned about various diseases such as endoscopy and functional spine disorders. The cases were highly centralized, and there were about 8 to 10 surgeries per day. There were about 30 residents in total, and with about half of them being women. Since there are limited positions for brain surgeons, many residents were uncertain about their future career paths, and some even pursued first training in countries like United States. Despite their busy schedule, the residents always made time their beloved espresso break. I also ordered the espresso machine after I returned to Japan. In August, I visited Mainz University in Germany, a large international hospital with over 1,000 medical staff and numerous international students. I had the opportunity to not only observe surgeries, but also participate in weekend on-call shift with Dr. Lagan and other residents. I was so impressed by their proactive engagement in academic activities such as case reports and research papers, which is less common during residency in Japan. And for a few days, I also visited the INI in Hanover, Germany. Professor Majid-Sami, the founder of INI, has made a significant contribution to the field of neurosurgery. He is at the age of 87, but he still performs surgeries. I observed his outpatient clinic and learned a lot about building trust with patients and neurological assessment. And in June, I visited Edinburgh, United Kingdom. The hospital I visited was a university-affiliated training hospital with many patients. Under Professor Andreas' supervisions, I observed a lot of surgeries and patient consultations for spinal disorders. He's a past president of European Association of Neurosurgical Societies. I was inspired by his commitment to foster knowledge sharing and collaborations across Europe to enhance the field of neurosurgery. The UK operates under the National Health Service, which provides universal healthcare, but I noticed several issues during my visits. Long waiting times and difficulty in managing hospital beds leading to frequent delays in scheduled surgeries, insufficient medical funding resulting in a shortage of doctors, and limited availability of catheter treatments. I also visited the Moi in Tanzania, the largest medical center in East Africa. In Tanzania, there is a shortage of both financial resources and physicians, which hampers accessibility of healthcare service for populations. I observed many cases where delayed diagnosis led to severe conditions such as advanced hydrocephalus and tumors. There are only 24 neurosurgeons serving a population of 60 billion people. In such a challenging environment, the staff did their best. The Moi also attracts students from around the world who are interested in healthcare in Africa, and I met about 5 exchange students there. In addition, neurosurgeons from Canada and China come to work for 1-year terms, and under their guidance, the cutting-edge spinal surgery equipment has been introduced. Finally, I visited a hospital in Toronto. Toronto is a major city with a population of 3 million, and it's a global city that attracts many students and fellows from around the world. Under the guidance of Dr. Assis, a vascular specialist, I learned about the craniotomy and vascular treatments and outpatient care. Every Friday, a resident study group is held, bringing together about 15 residents from 4 affiliated hospitals. In Toronto, many fellows come from other countries, which allowed me to deepen my understanding of my future career goals. With this, I conclude the facility introduction. Next, I'd like to discuss the differences between neurosurgical environment in Japan and other countries. My affiliated medical department at Nagoya University Hospital was more than 50 affiliated hospitals and performs over 10,000 surgeries annually. Our inpatient exceeds 20,000 annually, covering a wide range of diseases such as tumors, vascular disorders, function, and spine cases. And Toyota Kosei Hospital, where I'm currently based, is one of affiliated hospitals and serves as a regional core hospital for Toyota City, which has a population of 420,000. Our neurosurgery team consists of 3 senior doctors and 3 residents, making a total of 6 staff members. We receive about 10,000 emergency transports per year, of which over 700 are neurosurgical cases. We perform nearly 300 surgeries annually, with about half being emergencies such as SAH or trauma. We perform around 30 clippings and 20 CEAs each year, making the hospital specialized in craniotomy. However, CAS and other endovascular treatments are only performed a few times per year due to a lack of endovascular specialists, leading to case bias. Spine and also spine surgeries are performed by orthopedic departments, so there are no observation opportunity for these procedures. There is a case bias at each hospital, but our 4-year residence training rotates residents through four different hospitals, spending approximately 1 year at each hospital to correct this bias. However, depending on the rotation, it is not uncommon for some residents to finish their training without dealing with special spinal cases at all. Next, I'll talk about endovascular treatments. In the EU, only radiologists perform endovascular treatments, while post-operative management is often handled by neurosurgeons. Limiting this specialty to radiologists has resulted in a shortage of specialists, and more facilities are unable to provide 24-hour thrombectomy services. Additionally, due to lack of funding in Tanzania, advanced endovascular treatment cannot be performed. In Toronto, neurosurgeons, neurologists, and radiologists collaborate to perform endovascular treatment in a centralized environment, providing a high standard of care. On the other hand, Japan is progressing in line with North America, such as Canada. About 80% of endovascular specialists are neurosurgeons in Japan, and each year more and more physicians and neurosurgeons are specializing in vascular treatments. However, due to the large number of affiliated hospitals, some doctors face significant burdens. And there are cases where some doctors are on call throughout the year without any day off, which has become an issue. And in Japan, there are also gender issues in busy specialties like neurosurgeries. Female doctors often have to take on burdens of childbirth and childcare, which still poses challenges to their career development. Even though this fellowship, I couldn't find the fundamental solutions, but I observed that overseas environment made it easier to take paid leaves, paid vacations, and adapt shorter working hours, and they sometimes use housekeepers, all of which had a positive impact on childcare. Through this fellowship, I was able to understand the overseas medical environment better than before. It was also a wonderful opportunity for me to connect with many mentors and fellows residency, which is something I need to strengthen my training. By making comparisons, I was also able to understand the merits and issues of neurosurgical situation in Japan. Additionally, I was able to organize my future goals. Now I aspire to pursue a clinical fellowship abroad after completing my training as a neurosurgeon in Japan. Like this observation-based study abroad program, I now strongly desire to engage in outpatient care, surgeries, and research overseas after my training period. Thank you very much to everyone who supported me, and thank you very much for listening.
Thank you. Thank you, Dr. Shogo Yoshikawa.
Thank you.
It was a wonderful journey you had. And I give you best of luck for your future. So now I would like to invite our two fellows who are currently there in Fujita, Dr. Manali.
Yeah.
Dr. Manali.
Hi.
Hi. Can you introduce yourself?
Yes. Good evening, Dr. Kato and seniors. Can I share my screen? I've made a PPT. Yes. Can you see? I'm sharing my screen. Is my screen visible?
No, still not.
It is visible.
Yes. My name is Dr. Monali Patel. I am from India. I have done my MBBS and after that MS General Surgery. I worked as a general surgeon for 2 years in Mumbai. After that, I did my 3 years of residency at Topiwala National Medical College and DYL Nair Hospital, Mumbai. I recently finished my residency. Our hospital is located in Mumbai. It is a 1,300-bedded hospital with 30 beds dedicated to neurosurgery. I'm a member of the Skull-Based Surgery of India, the Cerebrovascular Society of India, and also international resident member of ANS and CNS. These teachers are my inspiration and I am following in their footsteps. My subspecialty of choice and research interest is in microvascular and endovascular surgery. And I plan to do fellowships in both and practice in Mumbai in future. So that's it. Thank you.
Thank you, Dr. Monali.
Yeah,
Thank
thank
you.
you.
So now I would like to invite Dr. Tawasul Ahmed to give introduction. And
Good evening, everyone.
morning.
Thank you for inviting me to this webinar. I want to share my screen. My name is Tawasul Ahmed. I'm a Sudanese neurosurgeon working at Al-Maknimir University Hospital in Sudan. Sudan is located in the northeast part of Africa, and the name derived from the Arabic word Bilad al-Sud, which is mean the land of blacks. And Sudan is neighbored by many countries, mainly the Central Africa, Egypt, Ethiopia, and so on. The capital is Khartoum, and it's considered the third largest country in the Africa, with more than 45 million people from more than 500 different ethnic groups. They speak mainly Arabic with more than 500 accents. The neurosurgery in Sudan started in 1971 by Dr. Abu Saleh, who started the proper neurosurgical practice in Ashab Hospital. In 1995, the first neurosurgery training program initiated in Sudan by Sudan Medical Specialization Board. And in 2000, by Prof. Arbab, the neurosurgery board established. Since its establishment, 74 neurosurgeons trained locally and abroad, 41% of them were a female, and Dr. Susan was the first female neurosurgeon. Since the program started, 58 neurosurgeons has graduated from it. Basically, I'm graduated from University of Khartoum in 2012, and I gained my membership in the Royal College of Edinburgh for surgeon in 2014, and got my master's degree in molecular medicine from Institute of Endemic Disease in Khartoum in 2016, and earned my MD in neurosurgery in 2022. And I'm registered in the Sudan Medical Council. I done my internship for 1 year in Sudan, and I worked as a medical officer in neurosurgery department in military hospital for 1 year, and complete 6 years of neurosurgery residence from 2015 to 2021. And I worked as currently I'm a fellow in Bantan Hospital, Nagoya, in Japan. Started in September 2024 today. As a neurosurgery specialist, I worked at Omdurman Teaching Hospital as a part-timer since I completed my MD. It is a large public hospital, serve about more than 400 million. And basically, I was working at Wad Specialized Hospital as a full-time job for 1 year. And the department there started in 2016. After the war, I established the neurosurgery department in Al-Maknimir University Hospital in May 2023. I worked there for about 1 year till July 2024. My cases in the last 4 years, we done about 13 neuro-oncology cases. We have the privilege to do the first neuro brain tumor operation in July 2023 in the province, and we had many cases of trauma, pediatric. The most of the cases was a gunshot cases to the brain and to the spine. This one of our cases, it's a supracellular bullet. We done about 4 cases. Bullet removed in 3 of them, and 1 we failed to remove it. The patient was 2 adult and 2 pediatric patient. 1 patient developed the diabetes insipidus after surgery. This is the image for a 30-year-old male. The entry point was from the right middle mandible. My basic interest in functional and epilepsy surgery, vascular neurosurgery, and microvascular decompression. Challenges in neurosurgery in Sudan. Political instability played a major role in the major and the top challenge in our country, which is in the war, which army conflict started in April 2023. And we lost all our neurosurgical centers, and most of the neurosurgeons had to leave the country. And we lost one of our neurosurgeon who was a senior surgeon, Dr. Abdurrahman, in the 13th of June 2023. He was working in the hospital when the firearm started, and we lost him. And currently, there is no facilities in the hospitals. In my hospital, there is no adequate training staff, and there is no the staff is not trained to deal with a neurosurgical patient. We have only 4 ICU beds and 1 mechanical ventilator in the whole hospital. And unfortunately, the neurosurgery training program has stopped, and many of the residents and consultants left the country. This paper showed the challenges in the neurosurgery during the armed conflict in Sudan. This showed some of the hospital which was destroyed, unfortunately, due to the army conflict. And this is we left with this basic instrument to work with it. And this was Sudan before the war. I thank you for listening.
Thank you, Dr. Tawassul Ahmed. You can stop sharing.
Okay.
condition is really bad in Sudan. I hope in future it will be better.
I hope so.
So now the webinar is now on the verge of completion, and I would like Professor 𝒂𝒄 to give final remarks. Please, Professor.
Professor Kato, you are muted.
For me, maybe that Ashish, you can give one word to Yoshikawa Sensei.
Yes. Thank you, Professor Kato. So just few things like Dr. Monali would like to talk to you in terms of your microvascular and endovascular journeys. I am my MBBS is from Government Medical College Meerut, so we are alumnus in one way, and world is very like a small place. So I wish you best of luck. Because the place you did your general surgery in, I did my MBBS in that college. So congratulations and welcome to the world of hybrid vascular neurosurgery. Shogo was here. I just want to mention just few comments about Shogo when he was here in Toronto. He used to move in the operating room as well in the angio suite, back and forth because of multiple cases in operating room as well as in the angio suite, and he was working along with 5 or 6 of my other colleagues in neurosurgery and endovascular neurosurgery. He's very much interested in open and endovascular surgery as well, and intends to come for a fellowship after 5 or 6 years, I suppose, by the time he finishes his residency. I've seen very keen interest in terms of him staying late nights in the OR, and although he was an observer, could not help much, but it's different from Japan. In Japan, like, you can actually scrub in cases, but unfortunately here you cannot scrub in cases. So but I saw him like staying for a long time and making notes in a small diary which he had. So it was very, very inspiring in a way to see him taking all those notes and learning from all of us here. But I wish him all the best for his future. I think I have given him some options about how to navigate his neurosurgical career once he finishes his residency. And I wish him all the best. And he has my contact details. I have asked him to watch a lot of Netflix shows in English, because communication becomes a very, very important part. And he actually has noted down in the diary as well. So it is something which is very important in my opinion, to talk to the nurses, to the paramedics, and if he starts working on now, I'm 100% sure that there are at least 13 different fellowships at the University of Toronto, and whatever specialty he chooses to be in, he can certainly apply here and come for 1 or 2 years here. So I wish you all the best, Shogo, and I think you do very well in neurosurgery.
Thank you very much, Dr. Assis. Now I become a Netflix heavy user. And I hope I'll return to Toronto someday. So I train as a neurosurgeon and also as English. Yeah, thank you very much.
This advice was given to me actually also when I initially came like 10 years back, Professor Kato, and sometimes it's just not about the English, about the accent. So sometimes I used to miss like a few things which were said to me initially when I was a fellow. So that's why I provided him that insight and passed on that pearls of wisdom which my professor gave to me many years back, and that helps to get that accent rather than actual English, and then it helps you to work very closely with the nurses and with the team. So I wish you all the best, and I think you are well prepared for that now.
Thank you.
Okay, thank you very much. So, Yoshikawa Sensei, you had a great journey in the world, I think. Congratulations. But I think you saw not only the developed place, but also developing place. So, what as a neurosurgeon, as a doctor, what you can devote to such patient who is underlying the developing countries, I think. That is the more important than English, I think. Of course, English is of course, very, very important for communication. But now your English is much better than before, I think. Thank you very much for your reports this time. And also, I'm very proud of that just two young ladies. He is, I think, leading the future, the women neurosurgery. Maybe 𝑑𝒓𝒐𝒂𝒔 is the senior female doctor. Maybe you can follow her. So we had a very good webinar today. Thank you very much.
Thank you, Professor.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye, everyone.
Bye.
Thank you, everyone.
Bye.